Well, it's great to be here today, and thank you very much for having me. And first of all, I just want to apologise that I'm not going to be around for most of the day. As Helen has already said, it might be quite a busy day in Westminster today. So I'm afraid I'm going to have to go back before lunch. But as I say, really glad to be here and speak to you. So about a year ago, we started the development of the National Cancer Plan. And I think that there was wide agreement from ministers, stakeholders, patients and clinicians that we needed a new cancer plan because there hadn't been one since 2015. And cancer requires a full system approach looking from prevention, diagnosis, treatment and ongoing support of patients to be able to tackle it. And that's why the government decided that it was going to develop a new national cancer plan. And I want to give you a bit of an overview of how we developed it and then what's in the cancer plan, and hopefully talk a bit about what it means for rare cancers, in particular like cholangiocarcinoma. So we launched our call for evidence, and I'm sure lots of people in this room responded to it. We had 11,000 people respond to our call for evidence. That included 7,000 people who were living with cancer or who had experienced cancer themselves, 2,000 people who had work carers for cancer, for people with cancer, and then a wide range of other members of the public, clinicians, and stakeholders from across the cancer community, so charities like AMMF, industry, and from academia as well. We also made sure that we involved the cancer community in the development of the plan. So we invited a lot of people to join our expert reference groups, which developed the policies and recommendations for the plan. We made sure that we had patients in each of those groups, as well as cancer charities, academics and clinicians, to make sure that we were getting widespread feedback into what the cancer plan needed to involve. And we also went out and we did some very direct engagement with the cancer communities. That included with patient groups, with community groups, with the Royal Colleges, industry, and with quite a few cancer charities, including quite a bit of work with the rarer cancers community. I think we got some very clear messages from that, and I think when it came to rarer and less common cancers like cholangiocarcinoma, I think in particular we had some very clear messages around what we needed to do. First of all, that we needed to do much more to prioritise and raise the profile of rarer and less common cancers. And we also heard quite a lot of very similar stories to what we just heard about the lack of awareness, the difficulties with early diagnosis, and also the lack of specialist treatment being available. But across what we heard through our call for evidence in our expert reference groups and our direct engagement, I think there were some very clear messages that we had to do much better to improve the outcomes for people diagnosed with cancer. When we were developing the plan, the government's broader 10-year plan for health was also being published. And the National Cancer Plan was designed to build on the policies and in particular the 3 shifts set out in the 10-year plan for health. Those shifts are analog to digital, sickness to prevention, and hospital to community, all of which we've tried to build into the National Cancer Plan. So on analog to digital, first of all, we're trying to make that happen for patients where they want it to happen. So trying to move more control over patients' care onto the NHS app, so that through the NHS app you are able to access your own appointments, your personal care plan, and where appropriate, details about your results and your upcoming treatments. Alongside that, we also want to make sure that digital is used for clinicians and for other staff in the NHS to make their jobs easier. That includes things like ambient voice technology to make note-taking and administration much easier for clinicians and staff in the NHS, and to make the NHS overall more efficient. Sickness to prevention, we all know that one of the best ways to improve outcomes for cancer is to prevent cancer from growing in the first place, and the 10-year plan set out very clear actions on prevention. The Tobacco and Vapes Bill recently passed, which will create the world's first smoke-free generation, and set out further actions on alcohol and obesity. We wanted to build on that through the National Cancer Plan with some more specific actions on prevention. So continuing our aim to eliminate cervical cancer through HPV vaccination and screening, and cracking down on use of sunbeds to reduce the risk from UV radiation. Finally, the third shift is hospitals community, so trying to bring care much closer to patients where it is appropriate. Now, in some cases, for cancer, you can't really bring treatment to the community more directly. So for things like surgery and radiotherapy, those need to be based in acute centres. And as we heard, when you're trying to treat a more complex and rarer and less common cancer, it may well need to be based more in a specialist centre. What we can do in cancer is try and bring the ongoing support of patients who have been diagnosed with cancer closer to them. And that's what we want to do with the advent of neighbourhood cancer care, to try and bring long-term support closer to cancer patients so that they can be supported to recover from treatment. In the cancer plan, we have three main ambitions. So first of all, we will meet the cancer waiting time standards by the end of this Parliament. So that is that people should be getting a diagnosis or all clear within 28 days of referral, that they should start their treatment within 31 days of a decision to treat, and that they should start their first treatment within 62 days of an urgent referral. We know that these things matter a lot to patients, that waiting for a diagnosis, waiting to start your treatment can cause a lot of anxiety. And we also know that these things are important for outcomes as well, that making sure that you can get treated quickly before cancer spreads is very important to improving cancer survival. That brings me on to the second ambition, which is that by 2035, 3 in 4 people diagnosed with cancer will be cancer-free or living well with cancer for 5 years. So that is across the index of all cancers, trying to improve 5-year survival to 75%. We're aiming to achieve this firstly by increasing early diagnosis. That has been a long-standing ambition of the NHS, to diagnose more cancers at stage 1 and 2. That's something that we want to continue. We know that improves outcomes. As we saw in the video, if you can catch cancers before it's spread, that gives you a much better chance of curative treatment. Alongside that, though, we also want to make sure that we are improving the quality of treatment and reducing the variation in treatment that is available to patients. So we know that, unfortunately, not everyone in the country gets the same level of treatment, that depending on where you live, you may be more likely to get high quality or curative treatment. And we want to make sure that that is not the case and that everyone has access to high quality specialist care. The way that we've worded that ambition, though, is the idea that people will be cancer-free or living well with cancer after 5 years. And that is because the third ambition is that we want people to have improved quality of life when they are living with cancer. And we know that for some people, they may end up living with cancer as a long-term condition. So our minister, who helped us develop the plan, who led the development of the plan, Ashley Dalton, she is living with metastatic breast cancer. So that was something that was very important to her, that we don't just think about either we manage to cure your cancer or not, but that actually we recognise that we want to give people the right support throughout their treatment and beyond their treatment as well. So to deliver those ambitions, the plan was structured around 6 key themes. I'm going to go over the first 5 fairly quickly and then try and talk a bit more about rarer cancers, but I'm happy to take more questions about any of those after. So the first one is to drive up NHS cancer performance, to meet the cancer waiting times by utilising the investment that the government has made in diagnostics and in treatment, but also making sure that the NHS is using that money as efficiently and effectively as possible to make sure that people are diagnosed and treated on time. Second, becoming a global leader in cancer outcomes, so that is driving up cancer survival through improved early diagnosis and improved treatment. Third, designing cancer care around people's lives, so giving people the long-term support that they need from a holistic perspective, so through the use of personal care plans, helping to support people to stay in work or get back to work where that's what they want, and providing more intensive and tailored support where that is necessary. Fourthly, we want to improve cancer research. We have a very strong life sciences and research sector in this country. We want to do more to build on that through and to increase access to clinical trials. And as I'll go on to say, we want to do that particularly for people with rarer and less common cancers. And then the final two chapters were chapters which have not appeared in any previous cancer plan. So we had dedicated chapters for children and young people to improve early diagnosis for them and to improve their experience of care and to prioritise rarer and less common cancers. So I think we heard very clearly throughout our engagement and throughout the development of the plan that the rare cancers community felt like rarer and less common cancers had not been prioritised and had not been recognised in previous cancer plans, and that was something that we really wanted to change for this cancer plan. Therefore, we've set out a number of key actions that we want to take for rarer and less common cancers. So first of all, we want to make clear that we are going to prioritise rarer and less common cancers over the next 10 years. We're going to do that by appointing a national clinical lead to the National Cancer Board to make sure that we are delivering for rarer and less common cancers. We are going to use the Concord project to make sure that we are measuring survival for rarer and less common cancers against international comparators, and we're going to do more work to improve the quality and clarity of data on rarer and less common cancers, including where possible to make data much more granular on rarer and less common cancers. So we're not looking at necessarily at broad categories, but being able to go into more specific cancers so that we can understand where we need to improve on performance, on early diagnosis, and on survival. Alongside that, we want to make sure that we're improving diagnosis specifically for rarer and less common cancers. So doing a more proactive approach to finding rarer and less common cancers in primary care. That means supporting GPs to make sure that they are recognising the signs of cancers, rare cancers. We also want to make sure that we are improving treatment for rarer and less common cancers. Part of that is that we, across cancers, want to make sure that more patients are being referred into specialist centres and getting the advice of a specialist MDT where that is appropriate. We think that that is going to be particularly important for rarer and less common cancers where there may be more need for specialist treatment. Alongside that, we are also looking at novel procurement routes for diagnostics and for treatments for rarer and less common cancers. So trying to look at whether there are other ways to try and bring diagnostics and treatments to market and to bring them into the NHS. Finally, we're looking at research for rare and less common cancers. So we're going to implement the Rare Cancers Act, which was brought forward by Scott Arthur, and that will be to appoint a research lead within the National Institute for Health and Care Research, and we will be prioritising research for rare and less common cancers and looking to increase spending on that. So the clock at the back is telling me I've finished with 50 seconds left, so I'm very happy to take questions now.